here Richard Sear from Northern Health, Emily from the Women's, Sharon from Mercy, and Sky also from Northern Health. And we have our wonderful speaker, Dr. Peter Jurcevic. And behind the scenes, we have Yvonne from the Northwest Melbourne PHN. And Dr. Jill Paulson will join us soon. It's a very busy obstetric evening, so Jill and Peter are sort of tag teaming through this workshop. So I'd like to begin with an acknowledgement of country. Northwest Melbourne Primary Health Network and the Health Services would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woiwurrung people, the Boon Wurrung people and the Wathaurong people. We pay respects to elders past, present and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in this session with us today. Just a little bit of housekeeping before we start. Everybody is muted and please ask questions only via the Q&A function. We'll do the questions at the end of each of the presentations because our speakers need to run away to their duties. The session is being recorded, so if you miss anything, please don't panic. You'll be able to watch the recording when Yvonne sends you the link and a copy of the slides. Can you please ensure that you have joined the session with your name that you've registered? It's really hard for Yvonne to work out who's Zoe's iPhone. If you're not sure how to change it, then please just send Yvonne a message in the chat function and tell her who you are, so as then she can mark your attendance, provide you with your certificate and your CPD for the evening. So this workshop is a collaboration between the 4 health services of the Shared Maternity Care Network, so Northern Health, Mercy Health, Western Health and Royal Women's Hospital. And we've been supported to bring you this session by the Northwest Melbourne PHN. So we need them to help with all our tech support, all our registration and of course our CPD points. So there's our contact details if you needed to contact any of us in coming weeks. So we have 2 fantastic speakers for you tonight. Our first speaker is Dr. Peter Jurcevic. Peter has 30 years of clinical experience in obstetrics and gynaecology. He is high-risk pregnancy trained and has delivered 7,000 babies to date. He's head of unit at the Royal Women's Hospital in Melbourne and a member of the Francis Perry House MAC. He has provided over 500 lectures, is a research collaborator at the hospital and University of Melbourne, and on the side, an avid cyclist, surfer, husband and father of 3. It's a very busy chap. Dr. Jill Paulson, our second speaker, is a clinical director of obstetrics for the Mercy Hospital for Women. In addition to this senior leadership role, she works as an obstetrician in both public and private settings. Jill has a focus on quality improvement, is closely involved with adverse patient safety event review processes, manages obstetric patient feedback for the hospital, and also runs the obstetric debrief clinic. Her driving goal is to provide patient-centred, collaborative, safe care to mothers and families. So just a quick update on health pathways and the obstetric suites. So as most people know, the health pathways are written by GPs, clinical editors with support from local GPs, hospital-based specialists and other subject matter experts. They're a great source of evidence-based medical advice, a way of reducing variation in care and providing guidance on referrals. There are health pathways on antenatal care, so specifically on the 2nd and 3rd trimester. So you can go in and find specific issues that may occur during that time. And so if you click through, you can look at the assessment and the management of things like decreased fetal movement, vaginal bleeding, etc. There's also directions on how to refer into, next slide, Richard, how to refer into the various hospital services and links through to their referral guidelines from the pathways. Next slide. So this is the list of the various antenatal suites that are on health pathways. So plenty of information there. The GPs are now able to record their CPD hours for reviewing pathways And if you're looking up anything, doing any research, you can click on the record CPD. And if you go through to the next slide, Richard, and it will come up with the how to use a CPD reporting tool. So you can put in the pathways you've looked at, any of your reflections, some learning notes, and it will record the time that you're on the various pathways, and you can save that as a PDF and submit it to the college for your points. So I think most GPs will have received information from Health Pathways about how to register. Other health practitioners, midwives, hospital doctors, etc., are able to register to use Health Pathways. So you can scan the QR codes and send a request for registration. Everybody will have an individual login then. Okay. You can also subscribe to receive the Health Pathways Bulletin, and they have great case discussions about various conditions. All right, so now I will hand over to Dr. Peter Jurcevic for his presentation on antenatal ultrasound findings. Thanks, Peter.
Well, thank you very much for the introduction. Thank you everyone for taking the time tonight to listen in to this talk. When I was asked to present and asked to think of a topic, ultrasound sprang to mind, particularly because of what a wonderful tool it is in the care that I provide to the women I look after for obstetric purposes. But I had to also recognise that if I'm presenting to largely a GP-based audience, it's obviously a different level of access to the machine technology, in the sense that I have one in my rooms and I'm able to use it each and every day to scan each and every patient I see at each and every visit. And that's really a nice thing to do. It's particularly nice for the woman on each and every visit to see the baby from the very beginning, from the earliest 3 millimetre sort of crown rump length fetal pole at 6 weeks, all the way through to a couple of days prior to full term when she's about to deliver, and we're looking at the head and all the structural bits and pieces, and getting to see the baby in its entirety, and it's a nice little moment for them. But for me, obviously, visually, I get to see some things that might otherwise not always necessarily be picked up routinely. So when we really sort of think about the circumstances in general practice, this is not quite the case. And so for those who practice women's health-based care, shared care for maternity patients, it's just really having a little bit of an understanding, slightly in depth in perhaps would be appropriate, but also knowing, of course, at the end of the day that you have your obstetric colleagues and secondary and tertiary medical obstetric units to be able to refer patients to if you need to for advice, and of course the multitude of radiological services out there. If we look at the topic, I sort of broke it down into the role of ultrasound, which may sound very obvious, but what I was wanting to really talk about is the notion of what is normal. So what is a normal scan? When there is a variance on a scan, so you have organised a scan that can be done either through a COGU specialist, so a obstetrician trained in obstetrics, where often the report detail may be a little bit more in it to kind of guide you in terms of any issues that might be seen and to describe the normalities that are seen, the normal scan findings, what variances you might find, and then of course the key take-home messages that will be relevant to, particularly to a general practice-based care provider for when you're looking at a scan report. Thank you, Richard. So, I mean, ultrasound scan technology has been around for a very long time, but when I was sort of just looking up the topic, it was brought to my attention. It was 1958 when it was first used as a tool. And I remember 30 years ago when I began my obstetric journey as a junior, ultrasound scan was very limited to very basic fetal biometrics, where we would just assess the BPD, so the head measurements, and we would do maybe some abdominal circumference measurements and a fetal length, and gradually algorithms were able to generate a prediction in size. And we could look at the amniotic fluid, and we could also maybe just start to do some basic Doppler, and certainly in early pregnancy see if there was a baby and a heartbeat. But of course that's now progressively changed, and the use of this modality is enormous. So from the very early beginnings, from that first early scan, either as a transvaginal or transabdominal scan, where from 5.5 weeks into pregnancy, we can often sight an intrauterine gestational sac, see a fetal pole and an early fetal heart, a yolk sac, and then of course all the way through to the end of the pregnancy. Importantly also the diagnosis and or exclusion of ectopic pregnancy, the incidence of which is about 1 in 200, so enough of a percentage risk out there in the population for those patients who present with pain where you're sort of umming and ahhing as to whether to do beta HCGs and scans or refer them to an emergency department for assessment, because obviously an ectopic, particularly a tubal ectopic that reaches size, will rupture a tube or the area that it's in eventually and can lead to bleeding and problems. Multiple pregnancies, we're seeing a lot less multiple pregnancies nowadays. And so whilst the average of multiple pregnancies in the population is about 1 in 80 spontaneously, we did have a large increase in multiple pregnancies years previous based on how IVF was conducted, where there was a tendency to put back multiple embryos. But in Australia, that is becoming much less commonplace. And so whilst we did see a bit of an increase in that finding of multiple pregnancies, mostly twins and less commonly the triplets and quads, and it sort of got up to about 1 in 70 at one stage, it seems to have drifted back to where it was at about 1 in 80. But it's nice to know. And also, if it is a twin pregnancy, from our perspective, what sort of twin pregnancy? So what we call DCDA, so separate sac, separate placental pregnancies, versus your monochorionic or monozygotic pregnancies, which are your identical twin pregnancies, where, of course, the potential for sac sharing or placental sharing can lead to slightly more issues. Obviously, we're becoming very focused on fetal growth and well-being. And we were talking prior to getting online tonight about issues around, what we're seeing in obstetrics at the moment with the declining birth rate and an aging maternal population having children. And essentially, of course, with women having their families a little bit later as a general rule, that does tend to occasionally bring with it some issues, of which potential growth restriction and fetal well-being are issues of this nature. And so having a scan as a tool to be able to assess a baby beyond the old school tape measure, where we just measure the symphysiofundal measurement, is a much more accurate way of assessing how a baby is growing and how the placenta is functioning. Fetal abnormalities, of course, very, very important, and that includes both your genetic and structural defects. And, as recently as this week, 2 days into this week, I've already seen or counselled a number of women, 2 of whom miscarried, that had trisomic and monosomic causes for their miscarriages. And also another woman who had an end of pregnancy procedure at 13 weeks for a Downs affected pregnancy that decided not to proceed with. And then another woman who had an ultrasound scan today only, and there was an issue with the cardiac structure that will require some form of further follow-up. So all picked up by a high detailed scanning, and all will allow us to now prognosticate and protect this pregnancy, the mother and the baby, moving forward. We're now starting to become better and better at potentially looking for evidence of future risk of preeclampsia and preterm birth, with various markers on scan, also some biochemical markers, and from a cervical perspective, looking at the cervical length. And when we look at all causes of potential issues of risk to babies and prematurity and cerebral palsy, prematurity is by far and away one of the biggest causes of harm to a baby if it's born early, and the risk to it from not just brain injury, but also respiratory and otherwise. And being able to protect and prevent potentially a baby being born early is really, really important. And of course, last but not least, your invasive procedures. So your CVS, coronary villus sample, your amniocentesis, and then of course also in utero procedures, where we're now able to do in utero laser for the management of twin-to-twin transfusion syndrome in monochorionic pregnancies, and also intrauterine transfusions for hydropic babies that might have been affected by Rhesus disease, and so on. So the ultrasound, year in, year out, it becomes just so incredible. And even the machines that we have as bedside tools, where a very small little laptop-based machine can still have a high degree of capacity to really look at a baby and, as a doctor in the rooms, be able to really see quite a lot compared to the old days where it was really just a bit of a snowstorm. As I alluded to previously, for most of you in general practice, you will be largely limited to a bedside symphysiofundal measurement, so the tape measure from the top of the fundus to the pubic bone. And as you would probably all be well aware, and it's very easy for us in medicine, it's a centimetre per week pregnancy. So we would expect that if you're 15 weeks, the top of the uterus to the pubic bone with 15 centimetres, likewise halfway at 20 weeks, 20 centimetres, 32 weeks, 32 centimetres, and then at full term anywhere between sort of 36 to 38, 40 centimetres on average. And then you would also be doing, obviously having asked the general questions of your patient, is the baby moving and so on, you'd be listening for the fetal heart and hoping to see that the fetal heart on your Doppler in your rooms, should you have one, is detecting that heart rate anywhere between 110, 115 beats a minute, all the way up to about 160 beats a minute. But I'm obviously very blessed that I have a machine in the rooms where I can do the scan, so I can see the baby. I can obviously still do a physiofundal measurement. I can do some fetal biometrics and measure the head and the stomach and or the abdomen, I should say, and the legs, and also visually kind of see what the AFI appears like. So I can get a general reading of the baby just by looking there without having to do any further detail. But our college has recommended, and it's not just for GPs, it's for obstetricians, that there are a number of scans that would be suggested that one has for their patient during the course of their pregnancy. So a dating and viability scan are usually done between the 6th and the 10th week, and for obvious reasons to see that the pregnancy is progressing and viable, but nicely for the parents to have a visual that they are now in the game. To at the 12 to 13 week mark, usually 13 weeks, do your nuchal scan, so the nuchal translucency scan. At the 20 to 21 week mark, traditionally 21, to do a morphology scan to look for the I guess that mid-pregnancy growth, placental location, and of course looking for any structural issues. And the third trimester scan at 32 weeks, truth be told, is not necessarily a set in stone must be done, but is certainly an optional scan, but is becoming more commonplace and would certainly be recommended for certain at-risk cohorts of women. And one that comes to mind is a person who's 38 or over and having a child. And then, of course, if a person has any other risk factors. But a lot of the time where there is the potential for, even with a normal symphysiofundal measurement, to not necessarily be absolute that you can ensure that the baby is growing to your satisfaction, there is, of course, always the chance that a growth scan will pick up either a macrosomic, so very big, or potentially a growth restricted baby that you might not necessarily picked up from what appeared to be a normal baseline abdominal measurement. And so that growth biophysical scan is certainly becoming more commonplace and gives you a sort of a biometrical marker, notwithstanding the fact that there can be up to a 15% discrepancy in what can be predicted as a centile and what the baby's actual weight will be. Thank you, Richard. So I thought I'd begin by looking at each of the individual scans that I alluded to, of which there were those 4 base scans at the different gestations, and just kind of go through specifically what is involved. So the dating and viability scan, as I said, traditionally will be between the 6th and the 10th week. And for GPs, and particularly for those of you who will be having women who will be going through the public sector, and I speak specifically to the hospital that I work at, but I know it tends to be relatively commonplace across most of the public units, both the secondary and tertiary level hospitals, is it is hard to get the women in by 10 weeks. And it's not uncommon for women to be presenting for their first visit to the hospital anywhere between 14 and 16 weeks in the pregnancy. So we as clinicians working in the public sector are enormously grateful for the GPs to be really beginning the antenatal care for the women. So arranging their baseline genetic screening, for example, if they were going to be doing carrier screening, of which you're all aware, the triple test is a free test, arranging a viability scan, and of course their general pregnancy blood tests, so serology, FBE, iron stores, thyroid, etc. But a dating and viability scan will have a number of benefits, and notwithstanding, most importantly for the couple and for the woman in particular, to see that she has a viable pregnancy on board. And there is nothing more special as an obstetrician, where I have the luxury privately to often be able to fit women in between the sort of the 7 to 10 week mark. And at 6 weeks, I'll often see a lot of women, not by preference, but these are usually women who have either had a problem, so some bleeding, and need some reassurances, or vis-a-vis, they might have had a history of miscarriage or a current miscarriage and need that early confidence that if there's a therapy in place, it's working and it sets the standard for where we're at. But if we look at a viability in a dating scan, I guess in terms of what is normal, a normal scan by definition, quotation marks, would be there is a singleton pregnancy, so our baby. We will see that there is a normal gestational sac, so it's regular in appearance with no distortion, no suggestion of any problems with from an chronic bleed or a distortion in the shape of the uterus. We'll see the yolk sac and a fetal heart, and the fetal heart will be at a rate that we will regard as being normal. And you'll always usually be able to see the cervix, particularly for a lot of the early scans where you have to do an internal scan to visualize the baby properly. So you'll see a long and closed cervix. And as I said, for the patient, it's lovely to see. And for you, it's nice, obviously, for your own personal reassurance. And generally speaking, if a woman has got a regular cycle, so we'll assume 28 days, relatively certain last normal menstrual period, so she knows when the first day was, the scan is usually going to measure that pregnancy, depending on the gestation, from say 6 to 10, to within 3 to 5 days prediction based on how the algorithm calculates it. And once again, it's really, really nice. Now, obviously at the time, if I just go back 1 second, Richard, thank you. If you go at the time, other things that we'll see, of course, are twins. So we will see 2 pregnancies, 2 sacs potentially, or 2 fetal poles or 2 fetal hearts. And obviously that will be very important. And there are features that we would want to look at very early on as obstetricians to prognosticate the twin pregnancy particularly. So try to differentiate between dizygotic, monozygotic to see if potentially there might be some sac sharing and so on. Vanishing twin is something that is worth noticing about. And I make comment about this because, as I just alluded to, a lot of these women may well be coming in to our tertiary centres for their first visit well after 10 weeks, which means they'll have come in beyond when they might have chosen to have your non-invasive prenatal test, your NIP test, so your Harmony panorama test. And as that test is a test that is assessing for trophoblastic DNA, so essentially placental DNA that's coming into the maternal bloodstream, if perchance you had a vanishing twin and there was now a surviving singleton pregnancy, then there would be the potential, if that twin was a miscarried pregnancy, and we know that in about 85% of cases a miscarriage can be a genetic anomaly, then there is a chance that there would be abnormal genetic tissue in the sample picked up on the NIPT test. And so that would be of value for the lab if you wrote it on the note, due date, woman's health, woman's weight and height as you normally put there. And then you say, oh, and by the way, it appears to be a vanishing twin. Just making that comment would allude to the lab if we ended up getting a result where there was maybe some genetic anomaly picked up. That may be the explanation, and the surviving singleton is actually okay. Or again, obviously a conversation that would be had with a specialist and an obstetrician. And of course, at the time of that scan, we have the potential to look outside the uterus and have a look and see if there's any other concerning adnexal pathology. So for example, an ovarian cyst or some sort, which may well just be the ovulation cyst, the corpus luteum cyst, but of course, there could be some other pathology that may require further intervention. Thanks, Richard. So when we talk about some variances that may be of relevance to you to either comment to the patient if it hasn't been by the sonographers. So as a general rule, my experience with sonographers is that with the COGU scanners, so your obstetric scanners, they tend to be very verbose during the scan. And so they'll articulate everything that they see to the patient even prior to when it's formally reported on. A lot of the time with some of the more, if I say politely, more generic sort of scanning services in the community, whether it's done by the doctor or the sonographer, they're a little less verbose and forthcoming. So the patient can often leave the scan without knowing necessarily what was seen. And if there was a bit of a numb and ah moment, not necessarily with any clarification of what impact that might have for the pregnancy. So there are situations where a woman has gone in for a scan, 8 weeks, they've had a look, there's a baby, a heartbeat, there's a yolk sac, but what they can see is an extrachorionic clot that could be anywhere from 1/2 to 3 or so centimeters in size, ever so slightly distorting the outside of the chorion, the gestational sac, and that can be without bleeding. And of course, that is going to sort of raise a concern. Well, is this evidence of a just misimplantation, but the pregnancy is going to correct itself and the sac will fill the rest of the cavity and the pregnancy is fine? Could it be a sign that maybe this is an imminent miscarriage? And if that's the case, is there the potential that there is that underlying cause for it, of which once again, 85% of the time there could be a genetic issue? And is there anything you can actually do about it? And it brings home the question where in obstetrics, and thanks to GPT and to Google, etc., a lot of patients will come in, have seen this and said, oh, by the way, I was Googling or AIing and they said I should have progesterone. And of course, that opens up the can of worms about the effectiveness of progesterone, the dose of progesterone. So for example, 100 milligram progesterone pessary at night versus 1600 milligrams of progesterone over 4 doses over the day, and what the actual genuine effect is based on evidence-based proof. And so there is often a potential component to this care plan where you'll see this clot. It's probably not going to cause any problems, but the patient will request, or you'll think about considering progesterone. And as a GP, should you be making that decision yourself, or should you do it in conjunction with an obstetrician to guide you? And I can say freely over this forum, as I said, the evidence for the use of progesterone for miscarriage protection is limited at best in terms of the actual effectiveness. You do the scan and everything's measuring well, and the sac and the yolk sac and everything's fine, but the fetal heart is under 100, so it's a slowish heartbeat. And the question perchance is whether that is just circumstantial to the moment or again, potentially reflective of an underlying potential risk. And so, you know, in that situation, should a repeat scan be arranged a week later for reassurance? And obviously for most people, they would err on the side of caution and do that to clarify their own concerns. And then, of course, the issue of when a woman is certain on dates, a regular 28-day cycle, she knows when she ovulated, she was planning this pregnancy. She was literally doing her beta-HCG urine check 2 days before her missed period. So she is pregnant and the scan is now measuring a week behind, which is relatively significant at an early gestation. There's still a fetal heart. So what does that mean? And so again, you start to and ah about absolutes and when patients ovulated and whether or not this is just a variation of normal, or in fact, potentially there is a potential imminent fetal demise. And again, raising the question of should a repeat scan be done? But again, these are the things that will come up on a scan that may well be normal, but may well raise questions. Thanks, Richard. So many years ago, we introduced nuchal scanning as a discernible way of assessing for potential issues with a baby from a genetic perspective. And of course, the one that sprang to mind and was most topical was, of course, trisomy 21 or Down syndrome. And this was all through the most wonderful gentleman, Professor Nicolaides over in England. And it's been a commonplace recommended assessment of a baby from a genetic perspective, certainly, since the early 1990s. And so fast forward to now, and with obviously NIPT testing at the 10th week, and also when we were also at one stage using the first trimester maternal serum screen, looking at some hormone markers, we were able to look at the value of this test as a way of assessing for the genetic health and well-being of our baby, and also for looking for any potential early structural defects. So when we look at a nuchal scan and usually done around the 13th week, and essentially what we're really doing is assessing the fat fold at the back of the neck. We're looking for a measurement that is preferably under 2.5 millimeters. We are looking to see if we can see a calcified nasal bone. We are having a look at best we can early structural development, of which we have a better chance of looking at the cardiac and the skeletal development than we would have at most of the other organ development. But nonetheless, we'd have it, the sonographer certainly would have a look around to see if there's anything that's raising concerns. And the detection of problems nowadays is incredible. So even aberrant right subclavians and early onset potential hypoplastic heart syndrome and early Epstein's and so on, they can pick these up on these scans. The sonographers and the machine technology is incredible. And then on top of that, also, they will be generally looking at the cervical length. And just to give you some statistics, a nuchal translucency scan, if that is the only genetic assessment that a woman does, from a sensitivity perspective, is about 85% sensitive for the detection of problems such as trisomy 21. So in other words, if the baby was to have trisomy 21, 85% of the time that would be picked up. And then a few years beyond when the scan was developed, and we did patients to increase that detection sensitivity rate up to about 92%. Now, of course, nowadays, for those of your patients who have the means and can spend $420, $430 at the 10th week of the pregnancy, the NIPT test, which is a largely chromosomally based assessment, that can detect chromosomal disorders such as Down syndrome with about 99.5% sensitivity. So it's an incomparably more accurate assessment for chromosomal issues. But what this nuchal scan, and I'll talk about this a little bit more in terms of, other things that can be assessed here, and then going back to some variances. Uterine pulsatility index can now be looked at. And if we see uterine artery notching, that can sometimes raise alarm bells that the patient could be at risk of having preeclampsia or growth restriction later in the pregnancy. And for an at-risk person, so a woman who's, say, for example, over 38, we would have probably already advocated that she was using low-dose aspirin and calcium prophylaxis from the early get-go of the pregnancy as a protection against those two issues. So if you were to see a woman either with that risk factor or a past history risk factor, or indeed just as this random finding, you would be possibly talking to this patient about whether there would be value as a way of trying to reduce her risk back to the population average in terms of preeclampsia, which is a 7% incidence, and IUGR growth restriction, by commencing on a low-dose aspirin with the confidence that it's a relatively safe drug. Now, common variances, and talking a little bit more about when I spoke before about the statistical sensitivities and so on. There will be times when, as I said, they'll go to a generic sonographer, not a COGO sonographer, so there won't be a lot of commentary made on the report beyond you'll see some numbers. So you'll see on the report that the baby was measuring for dates. It was consistent with the expected due date, 13 weeks. They'll do the nuchal measurement. They'll see the nasal bone, but the nuchal measurement was over 2.5 millimeters. So over what we would call a low risk cutoff. And so that is of interest, and particularly of interest when you do the NIPT test 2 or 3 weeks preceding, and the NIPT test was normal. And so the question then will, of course, be raised as, okay, well, if my NIPS test was normal, surely that means my baby's genetic, but it comes down to an understanding of what the limitations are of the NIPT test. It's taking trophoblastic DNA, it's looking at it, it's giving you mostly a chromosomal assessment, but it doesn't necessarily guarantee that there isn't some other genetic mutational defect or some other syndrome that may possibly be underlying. So it does annoyingly, even at 2.6 millimeters, like 0.1 millimeter over the cutoff, does open up that potential can of worms in terms of what this might mean from the baby's health and well-being. And then vice versa, if you have everything else normal and the nuchal measurement is under 2.5 and everything's fine, but you don't see the calcified nasal bone, is that a potential marker, a soft marker nonetheless, but a soft marker that the baby may have an underlying genetic issue? Now, more common than not, what will often happen if this baby is scanned a couple of weeks later, the nasal bone will have calcified and it'll be fine, and there is unlikely to be a genetic disorder, but there is going to be a small percentage increase in risk. And from a woman's perspective, a patient, a couple's perspective, they might say, well, if it's only 1 or 2%, it's still 1 or 2% more than it was prior to the scan. And that might be enough to trigger them to consider wanting to consider further testing. And in fairness to the general practitioner, and even to perhaps myself as a specialist obstetrician, it would not be uncommon for me for these sorts of findings to maybe have a chat to a geneticist just to get a bit of a sort of a breakdown on what their thoughts are and whether or not there would be a strong or slight whatever recommendation for further testing, such as invasive testing. Obviously, the question about if the uterine artery pulsatility index is raised, I partly alluded to that before, and that conversation about as a marker for preeclampsia or for growth restriction, whether they should be placed on some low-dose aspirin. One of the other things is that they will be often commenting about the cervix, and certainly should. It is really becoming more commonplace. And so we know that most cervixes in certainly a primary gravid patient will usually be well over 3 and even well over 4 and up to even 5 centimeters long. And as a marker from an early miscarriage and more potentially cervical incompetence prematurity risk, very reassuring. So what happens if you've got a slightly lower than normal cervical length and no pressure changes, no signs of any funneling, but the cervix appears less long than it should be? And I would certainly advocate that if you were to see a cervix that was, as I've just alluded to, less than 2.8 centimeters, it would be worth a phone call to a specialist to discuss what that means, i.e., should I be monitoring for cervical incompetence? In fairness to the general practitioner, no, you should allow us to do that. Should they be placed on progesterone as ironically, compared to miscarriage, a proven way of potentially helping to protect against prematurity? And even also more contentious is whether or not they need a cervical stitch placed to cerclage and tighten the cervix. And then, of course, for those who haven't done a NIPS test, who have done a nuchal translucency and have done a maternal serum screen first trimester blood test, and what happens is that you'll have on an algorithm, on a chart, your age, and your age will provide a genetic risk assessment for certain conditions, for example, trisomy 21. So population average for trisomy 21 would be 1 in 700, right? But once you get to around 40, it's going to be 1 in 100. And then as you become older, it'll become even higher risk. And, certainly around, say, 36, 37 years age, it could be around 1 in 200 or so. So there's going to be increasing age risk for that disorder. But if you were then to do an ultrasound scan and then you would do the blood test and then the algorithm calculates a combined risk, the combined risk will come back with a certain number. So let's say, for example, the number comes back at, say, 1 in 450, okay? And that's a really good risk. And we know that in the old days, we used to be always happy if it was over 1 in 250 or over 1 in 300. So 1 in 450 sounds great. But if you look at the chart, the woman's age risk was actually 1 in 560. So it's like, well, hang on a second. Her age risk is 1 in 560. This risk is now actually slightly higher. it's 1 in 450. It's better than what the cutoff risks that we used to worry about, 1 in 250, 1 in 300. What do I do? And of course, it opens up that Pandora's box where you've raised a doubt in your patient's mind and perhaps in your own mind. And so does it warrant any further investigation? And this is assuming, of course, notwithstanding there are no other issues. The nuchal measurement is normal, the nasal bone's seen, everything looks okay. So really, to be fair and honest, as we get to the end of this talk, and I'll sort of mention this to everybody, that whenever in doubt, we are here as specialists, the geneticists, the COGU scanners, to support you in your decision-making. But it is really important that you do read the report, because with great frustration and disappointment at the situation, and I felt desperately for this GP many years ago, but there was a report where the report was kind of alluded to be normal on the base of the report. So in fairness to the treating physician, said, yep, this is normal. But in actual fact, when you broke down the parameters on the scan, there are actually some abnormal variances on the scan. And that baby ultimately was found to have trisomy 21. And the couple, as luck would have it, sued for wrongful birth. So they claimed if they had known, they would have terminated the pregnancy. And they said, well, the signs were there. And I think it was very unfair for the GP to have to, be sort of, really the prime person involved in that call. But again, it was because the patient didn't make it to the hospital until around the 18th or 20th week of the pregnancy. So it was sort of down the track. Thank you. So the morphology scan is the third and essentially the third of the 3 scans that are absolutely recommended, with, of course, the growth scan being the other one that we will speak about shortly. So the morphology scan is essentially performed mid-pregnancy, so generally around the 20th or the 21st week. And really, when it was initially designed, it was really to look at how the baby was growing at that stage, where the placenta is, and also just to check the fetal structure. And so when we talk about what is normal, it would be that the placenta is well located, and we will also look at where the umbilical cord is attached. And that's with reference to examples of, for example, a marginal cord. So a marginal cord, if you think about this logically, if you look at a placenta with a marginal cord as like a tennis racket, with the cord coming in as the handle to the racket, the cord then splays out all the vessels across the entire placental plate. And so the theory would be, if it's coming in marginally rather than centrally, it may not be able to use the entire surface area of the placenta to nourish the baby. And so as a result of that, there is a small association between a marginal cord and, of course, the risk of growth restriction. And so we would always advocate for doing at least one growth scan later in the pregnancy. And vis-a-vis, we expect that around about 15 or so % of placentas are going to be sitting low at the beginning of or mid-pregnancy. But we'd be pleased to know that only 2% remain low at the end of the pregnancy, what we call placenta previa. So indicating statistically that well over 90 or so % of placentas will shift. And just as a reminder, a placenta is not migrating itself by physically shifting. It is attached to the uterus near the cervix. And of course, as the baby is growing vertically upwards from the cervix and expanding the fundus away from the cervix, the placenta is attached to the wall of the uterus, and of course it gets dragged away, which means for those women with a low placenta, particularly those that encompass or cover the entirety of the cervix, there will be a risk of bleeding because of the placenta being attached partly to the cervix, which is fixed, partly to the wall of the uterus as well. And of course, as it's dragging away, it can bleed. I guess as a GP clinician, if you were to see that, apart from reminding the patient that most of the time they'll shift, and to also advocate for a follow-up scan at 32, 34 weeks to assess that it has indeed shifted, you might be recommending some basic things to the woman in terms of avoidance of penetrative vaginal sex, for obvious reasons that the penis might irritate the placenta, and also maybe just levels of extreme exercise, just not overdoing the levels of exercise to reduce the risk of potential local engorgement and bleeding. Once again, we are looking for the structure. So the fetal structure is normal, and we know that about 2 to 5% of structural abnormalities will be picked up at a 20-week morphology scan. Of course, notwithstanding what the consequences of that abnormality will be. So, for example, you might see a very subtle abnormality which will have no physical or long-term consequences to the baby. And then, of course, it can go all the way to quite significant structural defects like a severe hypoplastic left heart or a major cranial anomaly or something where it might have a really significant prognostic implication for that baby and will then allow couples to do further testing, further counselling, and even consider an end of pregnancy decision if necessary. We're looking at fetal biometry, and essentially by that means we're looking at whether the baby is growing for dates and measuring appropriately, because we will have in about 1 or 2% of cases a baby that will show early onset signs of IUGR growth restriction. And often in that situation, annoyingly, the ship has sailed, so it's unlikely there will be any therapy we could instigate for that. But nonetheless, it would still be good to know if that's an at-risk situation and would allow us to make sure that we put the appropriate monitoring in. We're looking, of course, for a robust cervix, because when it comes to cervical incompetence, which usually is going to occur between about the 16th and the 26th week, and of course risks of extreme prematurity, which are the 23 weekers up to say 28 to 30 weeks, if there is any potential for that baby to deliver prematurely, and there is the potential for us to be able to prevent that in any way, we would want to know that. So having a cervix over 2.5 and ideally over 3 is extraordinarily reassuring. And of course, while we're visually looking at the baby and the structure and the size and where the placenta is in the cervix, we can also see if the amniotic fluid index appears to be normal. Now, other things that will be assessed, of course, is when we look at the cervix, if there's any pressure changes or funneling as an additional marker. A marker that would be potentially an indication for that really significant problem of prematurity risk. And again, the conversations had about emergency cerclage, progesterone, rest, changes in physical activity, so on and so forth. Thanks, Richard. Now, with an ultrasound scan, I'll gloss over this slightly quickly, because I think in fairness to the general practitioner audience, there needs to be fairness in what you absolutely would need to know. But I like to mention these because pleasingly you might see a few of these things and you'll be pleased to know that in almost all cases, there will be no actual problem to the baby, notwithstanding the fact that it might require, a further conversation with a specialist COVU sonographer or obstetrician. So we'll sometimes see where the choroid plexus cyst, which is where the cerebrospinal fluid is being produced in the choroid plexus, because the glands that are producing the cerebrospinal fluid are glandular in nature, they're predisposed to forming little cystic formations. And so choroid plexus cysts can not uncommonly be seen and will be very rarely of any size or any significance in terms of any brain shift or brain compression to cause any risk to the pregnancy. We also will sometimes see, and you might commonly hear of this, pyelectasis, which is the renal swelling. So the swelling of the renal pelvis or even the ureters, and often it'll only be about a 1 or 2 millimeter swelling or dilatation, I should say, and even can be bilateral. Now, interestingly, we're pleased to know that this is actually all to do with progesterone. So women have got a lot of progesterone in their body in pregnancy, and there is a very, very interesting process biochemically and physiologically in how progesterone crosses to the fetus, is converted by the placenta into the estriol precursor, which is the large circulating estrogen in a woman, and goes back into the woman's circulation. But progesterone by its very nature is a relaxing hormone. So in pregnancy and with relaxin itself and progesterone, there's probably a dual benefit from the patient's perspective in preventing the muscle wall of the uterus from contracting, so you can grow a baby without expelling it, and also just keeping the cervix calm, for want of a better term. So in other words, it's protecting the baby to allow it to grow to full term. But being a relaxing hormone, everything relaxes, and so progesterone is a culprit for a lot of the things that a woman will feel, from constipation from a slow bowel, all the way through to laxity in the joints and getting sore back and so on. But if the progesterone is crossing the placenta as a relaxing agent, not only can it relax the woman's ureters, so we often see hydronephrosis on a scan in a woman, we can actually also see it on a scan in a baby. So I'm always very happy to reassure a woman when the scan shows pyelectasis, which is the renal swelling. It's probably progesterone based. It is unlikely to reflect that there's a risk of fetal reflux nephropathy. We'll do a repeat scan at 32 weeks, where invariably it's usually dissipated and it's back to normal measurement. And if it is still seen at the 32-week scan outside of really significant dilatation to, I guess, allude to us possibility of urethral valves or megaureter or all sorts of other significant conditions in the baby, we do a scan of the baby 6 weeks post-birth. Of course, all of that hormone is dissipated from the baby's body. The kidneys shrink back to normal, and lo and behold, there's no actual problem. And of course, for those rare cases where it was an indicator of ureteric reflux, we can allow the pediatric team to get on top of that quickly to protect against renal disease. Sometimes we'll see borderline length of the long bones. You'll be pleased to know that that's unlikely to reflect any issues with dwarfism or anything of that nature, but it's always going to be something that will be of interest. More commonly, when the scan is done and it's commented on, you'll look at the mother and the father or the parents, and you'll note that they're short. So it's probably a normal variance in relation to their own personal size. An echogenic cardiac foci, I would understand as a woman patient, if someone said, oh, you've got an abnormality in the heart, that would raise panic. But what's interesting is an echogenic cardiac foci is actually just calcification of the valves in the heart. So the chordotendinii, which are attaching, so the little ligaments attaching to the valves, become a little bit more prominent or calcified, and we can see that. And pleasingly, it doesn't cause dysfunction to the valve or the heart, and is usually of no consequence. When we see calcification in the bowel, in years previous when we didn't used to do cystic fibrosis screening on couples, that would have been something that would have come to mind. Is this a risk of having cystic fibrosis as a marker? Thankfully, most couples are screened for that nowadays. And generally, when we see calcified bowel, it's usually just that, it's just the variance of normal, but it would raise the possibility of conditions, and in particular, potential infectious conditions, one of which would spring to mind is CMV. And so that would be something where we would probably normally recommend that you do get a specialist opinion if that was noted on a scan, to allow us to consider serological testing and any other further testing, just to ensure that we're not missing anything. I spoke to you about the cervix, and a long closed cervix is good, but what if it's long but there's funneling? And does that funneling potentially mean that there's an at-risk change for cervical incompetence? And also, what do you do in relation when the placenta is over the cervix, which I alluded to before in relation to just some general advice about mitigating activities, sex, etc., to protect against bleeding. Of interest with some of those structural variances I mentioned, choroid plexus, cardiac foci, long bones, calcified bowel, etc. Years previous, when we used to see these and we didn't have NIPT testing, which is, as I said, a very robust assessment for genetics, including Down syndrome, T21, what we used to do is we would have that first trimester nuchal scan and maternal serum screen, which I spoke to you about previously. And what we would do is we would have generated a risk estimate, and hopefully that risk estimate would have been above the woman's age risk. But if we saw one of these soft markers, what we did was we had a little formula calculation where we would adjust the relative risk for that marker. So for example, a woman would have been told she's got a 1 in 800 chance of having T21 based on her nuchal scan maternal serum screen, but there was an echogenic cardiac foci, and that might have changed the risk by 2 or 3-fold, which then brought the risk down to maybe 1 in, say, 300. Thankfully, that 1 in 300 was still above our recommended cutoff, so that was okay. What was always challenging was when a woman had a slightly lower risk initially by her age or the scan, say 1 in 400, has an abnormality and the risk marker changed the prognosis down to below the cutoff, and then it raised the can of worms of whether the baby was at risk of a genetic disorder. And so not uncommonly, women were having invasive tests, amnios, etc., to exclude that, thankfully knowing that well over 95% of the time, the baby was usually okay. So this is just a couple of images of, you can see on the left there, the little calcification there. And again, that's just the chordotendinii to the valve. And then on the right-hand side is just, it's hard to properly describe, but a very mild pyelectasis of about 1 millimetre or so above average on the left side, which would have been reported on, and then would have, of course, recommended to have a repeat scan at 32 weeks to assess to see if that has now settled down. Now, I mentioned earlier that it's becoming much more commonplace now for the growth and biophysical scan at 32 to 36 weeks. And there are certain at-risk pregnancies where this would have already happened as a matter of course, and probably already had a series of growth scans prior. And certainly for the aging population nowadays, we'd be more commonly doing it. But the big question that really begs itself is, should everyone have this? You know, can we be absolute that if we're doing a symphysiofundal measurement and a fetal heart with a Doppler, that is good enough? And, you know, argue the purists will say, yes, it is, but in actual fact, there is still a chance that problems can be missed. And if you look to the right of the slide here, you know, previously missed anomalies can be picked up on this scan, which would be of use to the couple to know and for the pediatric team in prognosis and working ahead. If we do it and we do find that there is a growth concern, it will allow for increasing monitoring and the potential for earlier delivery to protect against an at-risk pregnancy from potentially ending up with a compromised baby or even stillbirth. So when the scan is done, we would be doing the estimated fetal weight, and that's a combination of the head size, abdominal circumference, and the femur length, with the abdominal circumference being the most prognostic marker for growth. And then the placental function testing, which will of course include the obvious things of looking at the fluid level around the baby. We can now do pulsatility indexes on the cord ratio to see that the blood is moving forward without resistance. The middle cerebral artery in the brain, which basically, if the flow is predicted as normal, is a good marker for adequate oxygenation, and even in situations where we're assessing for fetal anemia can be a useful marker for that. And the ductus venosus, which is more commonly probably looked at for the really severely growth restricted babies, where because of the level of prematurity, we're using that as a last course marker to help to protect against delivering a baby worrisomely prematurely. These are things that can be looked at. But obviously, when that scan is done, it's all well and good when it's all reported as normal, and that would be extremely reassuring. But if we go across to the next one, thanks, Richard. The question, of course, be what would be the common variances? So common variances are going to be the ones where you've got the placenta. If the placenta was still over the cervix or right on the cervix at 32 to 34 weeks, that would be expected that that cervix is unlikely to shift in time to allow for safe passage of the fetal presenting part through the birth canal. And so it would be expected that you were looking at having a placenta previa, and kind of like a cork in a wine bottle, you can't get the wine out with the cork in, well, you can't get the baby out with the placenta in the way. And that would be presumably therefore leading to needing to have a cesarean section. One of the slight variances is the one where you've got the placenta that might be around, say, 1.5 to 2 centimeters from the cervix, where there could be still more time for that placenta to shift, particularly if it's anteriorly rather than posteriorly. And so we would probably recommend another scan again 3 or 4 weeks later, particularly for the woman who's very keen to try to have a vaginal delivery where possible. And then, of course, if you get a situation where you've got a baby that appears to be growing well, so we'll say arguably 50th centile, but you look at one of the prognostic other markers of fetal well-being for the placenta, so the AFI, the SD ratio, the middle cerebral artery flow, etc., and it turns out that one of those parameters is abnormal. So is that going to be a false positive or a true positive, and placing the baby at risk? So a lot of the time, by the time a woman's getting to this stage in the pregnancy, except for those of you who are doing shared care, most of the time these women would probably be in a hospital-based care program or a private doctor's care program, and we would be making that decision. But perchance, if you've ordered that scan and you see these findings, it would be nice to sort of have a brief understanding of what they mean. I think really the key, if we move forward, thanks, Richard, is that we are here, and I certainly say this to all of the GPs who I commonly receive phone calls from. I'm very, very, very happy to take a quick phone call to give you advice. The hospitals are very, very, very happy, particularly in the public sector through their emergency departmental birth suites, to take the women in if they need to be seen. And certainly for my patients obstetrically, I'm more than happy to fit people in each and every day to see them when there ever is a concern. So as much as we might look at a lot of the information provided tonight, and there can be degrees of really it's obvious and some more highbrow stuff, there is always going to be someone that you can call and speak to whenever you need any advice or help to support you to make sure that problems aren't missed or problems are dealt with. So that's the large summary of my talk tonight, and I hope it was of use to you, and I'm also very happy to take any questions if you'd like. Thank you.
Peter, that was a very great talk and very relevant to the scans we see every day come across our inbox. I've got a couple of questions. I know we've got till 8 o'clock, so I'll just start with a few. One of them is if the choroid plexus and the echogenic cardiac foci are variants of normal, why is it reported?
So again, this goes back to, I finished off that sort of part of the presentation by reminding you that years previous, we used to have these relative risk ratios where we would compare the previously ascertained risk, because if you go back to the first trimester nuchal translucency scan, it's a risk assessment. So it doesn't say the baby has Down syndrome as one example of a genetic problem, it says the baby may. And then the same with the combined test, the nuchal translucent maternal serum screen test. It says the risk of the baby having a problem is X% or 1 in whatever. So when you saw these anomalies, you were then obliged to say, well, when you see smoke, there may be fire. So if we saw a cardiac foci, or if we saw pyelectasis, or if we saw a choroplexus cyst, we would then adjust the risk value. Now, once again, from a pure chromosomal problem, for those who've had an NIPT test, that has largely ruled those out. So really, for all of those issues, they are not actual true structural issues. They are more variances. The pyelectasis does need to be followed up, because you would hate for a baby to be born with missed reflux nephropathy, which leads to kidney disease and damage. But again, most of the time, that'll be a self-resolving problem. So it's the genuine short bones where there is a genuine risk of either growth restriction or dwarfism. Again, dwarfism very rare. Or the calcification of the bowel, raising the possibility of some of those torch anomalies, so your CMVs, etc., where that would require a little bit of a more advanced notice. But as a general rule, you would see very few geneticists and or obstetricians with no other concerning findings beyond just an echogenic cardiophysi, just a singular choroplexus cyst, just pyelectasis, who would recommend that you do invasive screening. That would be uncommon to recommend.
Thank you. We've got a question about COGU scans. So it can be an issue about access and cost. So one of the questions is, if the woman is choosing just to have one of their scans as a COGU, which one should it be? And should we be referring all women for a growth scan in the third trimester?
Sure. Excellent questions, both. My COGU colleagues, I can vouch without question on their ability to produce a scan of absolute tertiary quality. So every scan will be comprehensive, usually articulated to the woman, and unlikely to have missed anything. So, hats off to my COGU colleagues. Gratuitous plug. Now, in terms of obviously your, and I say sensibly in use of my words, generic scanners, we have to, of course, remember that our generic radiology colleagues, who are well trained, by the way, may be doing a mix of scans in the day, from scans of babies through to scans of arms, through to scans of abdomens, through to hernias and so on. And so the question is always going to be the ability to be able to reduce that absolute level of requirement from the scan that I've alluded to in the talk tonight. Now, this shouldn't be misinterpreted that they can't. It's just obviously just an acknowledgement of trying to compare the two different types of apples. Now, from my perspective, I don't think a COGU scanner needs to be doing a early first trimester scan necessarily, because a good quality radiologist can spot a pregnancy in the uterus or an ectopic and assess for gestational sort of measurements and so on. The nuchal scan, for the most part, as a general rule, if we limit it to looking at the nasal bone, the neck, any very subtle early structural stuff and so on, again, generally speaking, a pretty good radiologist can do that. And whilst a good radiologist can do a morphology scan, I would certainly say, without exception, a COGU scanner would do that better. And then again, coming to the third trimester scan, should everyone have one? Again, it's not absolutely college endorsed. So if you said to me, what does my Australian College of Obstetricians and Gynaecologists recommend? It's not you must recommend it, but there's certainly advocacy for suggesting for all of those high-risk cohorts. And I know a large percentage of my colleagues now do it. Again, remembering I have the luxury of having a scanner in my rooms where I can do a very, very quick, almost in 2 or 3 minute biometric assessment and biophysical assessment of a baby that doesn't require potentially a $400 or $500 scan, less the rebate, in a COGU situation, or $200 plus. So I'm very, very, very mindful of cost to patients at the moment. I desperately bulk bill as much as I can for them and really try to limit unnecessary testing where I can, if I feel that my level of clinical acuity can keep them safe. So short answer, not everyone absolutely has to have a growth scan, but it's certainly becoming more common.
Thank you. And Peter, we've just got time for one more, and that is just a clarification on the recommendations with a low-lying placenta. Is the recommendation to avoid strenuous activity and penetrative sex just when it's low-lying, or when it's placenta previa in the third trimester?
It's a great question. So for a person who has a centralized placenta previa at 20 weeks, so we'll call it the old school grade 4, it's right over the cervix. It's statistically very unlikely to shift. It is likely to remain centralized. It carries a risk of bleeding. And then, of course, if you imagine that there's penetrative sex, that would potentially disrupt the placenta and cause bleeding. So that would be recommended to avoid. And when I say penetrative sex, but penetrative vaginal sex, of course, patients are able to be intimate in any number of ways. When it comes to the strenuous exercise, there is no absolute sort of information literature to say that that is going to promote or provoke a bleed. But it is commonplace for us to say, if you've got a major grade previa, you shouldn't be going on a long haul flight, long distances. And you should probably be sensible in just how significant a level of activity and strenuous exercise you push yourself through, because you're understanding that obviously with every level of exercise, heart rate, cardiac output goes up, you're increasing the placental engorgement potentially, and you always wonder about the risk of that causing bleeding. So I'd always advocate for just keeping it a little bit more simple. Those slightly minor grade ones, those ones that are adjacent to the cervix, sort of a grade 1, grade 2, probably going to shift. I'd probably still be saying to them, you may best be advised to be cautious with penetrative sex, but the exercise recommendation is probably, to be fair and honest, overkill. Again, assuming they don't bleed. And then, of course, that changes things.
Okay, I'm just going to ask one more because I just thought this was quite interesting. I'm not sure if you ever come across it, but fetal sex in the NIPT being different from the fetal sex on fetal morphology scan at 20 weeks.
Yep.
That was the question. I'm not sure if I've ever come across it, but is that something we need to be mindful of?
So
would that happen a lot?
So a COGU sonographer would say that they can detect the male genitalia to within 99% confidence intervals at 21 weeks, and a female maybe up to say 98%. So maybe that 1% variance in distinguishing labia from scrotum penis. Now, the NIPT test to date, in all of the tests that I've done in terms of sensitivity and fetal sex detection, has been, dare I say, 100%. But here's an interesting conundrum. One of the women that I mentioned earlier who sadly had a monosomic miscarriage, she did an NIPT test at 10 weeks and I'd scanned her at 9 weeks and the scan was showing a viable progressive pregnancy. NIPT test at 10 weeks came back as 46XX. And then she went in for a 13-week nuchal scan and she had an unexpected 11-week miscarriage. So the baby had succumbed unexpectedly 1 week after the NIPT and 2 weeks after my scan. So when I did a suction curette, I said, let's karyotype this because it's very unusual to miscarry a viable pregnancy, a genetically normal pregnancy. I want to clarify that because otherwise it's going to open up the can of worms of autoimmune thrombophilia screening and trying to, protect a future conception. Lo and behold, she had a mosaic pregnancy where it was a 46XX, but 35% of the sample was monosomy XO. So in other words, she probably had a placental anomaly that contributed to this demise. Now, when we're talking about XY on a NIPS test and XX appearing on a scan versus say XX on the NIPS test and it looks like it's got a penis, I don't even know how I could probably answer that one. I'd probably have to speak to my genetic team to see if that's actually ever happened. But the NIPS test, it would be very rare for a NIP test result indicating gender to indicate anything other than the gender. Unless there was some weird vanishing twin thing, but even then that would pick up some sort of a mosaic component. So I probably can't give you the best answer for that one, but it would be interesting if that was true.
Yeah, I'm sure it's very rare. That's why I had to ask it. We'll compile the other questions and pass them to you. We'll bring on the next speaker. So if people have other questions, please continue to type them in the chat and we'll try and get them all answered, even if it's not in this webinar. But Peter, thank you so much for your time. That was really, really helpful.
My pleasure. Thank you everyone for listening in and good luck with your rest of your year.
See you later. Thank you.
Bye.
All right. So I'd now like to introduce Dr. Jill Paulson from Mercy Health, who is going to speak to us on the topic of birth trauma and patients declining recommended care. So thank you, Jill.
Thanks so much, Joanne. Thanks everyone for having me. I'm really excited to be able to talk about this topic with you. I'm passionate about how we can improve maternity care for patients to reduce birth trauma and to be a united front, all working towards delivering babies safely and keeping women happy and safe. Wasn't that a fantastic talk about ultrasound? It just shows the complexity of ultrasound scanning and how much it's evolved over really even just the last 10 or 15 years. And I was just reflecting that we can do such amazing things for scanning of fetuses and investigating women in pregnancy, but it'll all fall down if we don't have good relationships with our patients and we're then able to deliver them safely. So that's sort of what I'm passionate about, and I'm going to touch on a variety of different areas in relation to that tonight, and really look forward to some questions at the end. Thanks, Richard. So I'm going to just take you through a bit of the theory around birth trauma. For the last couple of years, I've been fortunate to run the debrief clinic here at the Mercy. I just came from that this afternoon, and it certainly teaches me something new every single time I see a patient through the debrief clinic. So I'd like to sort of share some of my learnings with you about that. Just talk you through some of the postnatal care options and how we're increasingly able to care for women beyond the delivery, which isn't something that's always been well done in the public system, I think, in the past. I'm then going to take you through some work we've done in generating a guideline to cover the situation where patients decline recommended obstetric care. And because I know these patients often come and see GPs as well, and just to give you the framework that we use that you may find useful as well, and to understand the kind of conversations and where we're heading with this with patients. And then finally, just some examples of where we're really trying to shift the focus and improve the way we do things such as obstetric, such as operative vaginal birth, to do it in a more patient-centered way, to reduce birth trauma and to keep our patients feeling a bit happier and safer. Thanks, Richard. So this is a sad slide, and it unfortunately is not uncommon for these things to reach the media. And this is just in the last couple of months. So just a little bit of Googling revealed all sorts of really distressing and awful situations where women are choosing to have home births outside of the mainstream hospital home birth programs. And sometimes even free birthing. And that's certainly something we have seen has become much more common since COVID times, with a real growth in the free birthing movement in Melbourne in particular. And in fact, one of our colleagues is doing a sabbatical work on looking at outcomes from free birth and the number of looking at in Victoria, how many babies we've lost each year in free birth settings, and the cerebral palsy that can go along with that. So it's a real problem, and it's such a tragedy to lose a baby right at the end, when hopefully we can provide safer options and keep women on side and know that family are going home with a safe baby, safely delivered baby. Next slide, please. So Safer Care Victoria have released a statement themselves about free birthing, really encouraging women to only engage with APRA registered professionals for their deliveries and just warning them. And of course, I haven't really gone into this in much depth in my talk tonight, but there's a lot out there on social media, and that's what we're competing against. So this just a reminder, hopefully, to patients to stick with registered professionals. And of course, there was the birth trauma findings from New South Wales that is well worth having a look at if you're looking at, if you're interested in this sort of thing. There's a nice executive summary, and RANZCOG themselves have done a recent, a couple of years ago now, isn't it? A whole magazine all about informed birth and birth trauma. Thanks, Richard. And I'm starting with this slide and ending with it because I just want us to all remember there's no point having professionals pitted against each other or being judgmental about choices that patients are making, because the obstetrician and the GP obstetrician and the GPs doing shared care and the midwives and then the patients and their families, at the end of the day, we all want the same thing, which is for these babies to be born safely, for women to be safe, and for women and staff to have a good experience. So that's our key driving goal. So what is birth trauma? I'm sure all of you have seen women who have been affected by this, but sort of one of the typical definitions is a traumatic childbirth experience in relation to the experience of interactions or events directly related to childbirth that causes overwhelmingly distressing emotions and reactions for the woman, that is associated with short or long-term negative impacts on her health and well-being. Thank you. And how common is it? Well, pretty common. So some of the studies, the Keedle paper talked about women experiencing short or long-term consequences in the vicinity of about 1/3 of women. We have a fantastic senior midwife here who's doing a PhD on birth trauma, and she surveyed women presenting for their second or subsequent pregnancy. And of those surveyed, which was quite representative, 28% disclosed that they'd had previous negative or traumatic birth experiences, and they were fearful, therefore, for their current upcoming birth. That's a 1 in 4. And then there's the more formal definitions of childbirth-related post-traumatic stress disorder, which is a stricter, more stringent criteria for diagnosing, and that's about 4.5% overall. But in high-risk women, such as those with pre-existing mental ill health, previous PTSD, sexual abuse, or poor social supports and low socioeconomic status, we might see an incidence of that disorder being diagnosed in as many as 12% of women. So super common conditions. Thank you. And this is a long list, and some of them are fairly obvious. I think the thing that I see most commonly coming up is, of course, people who are from disadvantaged groups or who are vulnerable to birth trauma. I think the thing that I see the most is those who've had a past history of trauma, of sexual abuse, who have got significant mental health problems. But certainly those who have an intense fear of birthing for the upcoming delivery, those who've needed more intervention, and then the experiences of women in labour can really predispose them to developing birth trauma, including a sense in labour that they're not being well supported, that their staff are panicking or anxious or don't have the situation under control, leaving them feeling abandoned or unsupported, experiencing very, very intense pain, which of course we know is impacted upon by our own trauma histories. Women who fear losing their life or losing the life of their baby. And we can't forget the partners where they fear losing their partner or their baby as well. And we're just increasingly becoming aware of the trauma for partners and of course for staff too. Thank you. How is it manifested? Well, in a variety of different ways. A fairly self-explanatory list here. It can be physical, it can be emotional. There are obvious mental health disorders that can develop as a result of it, including formal diagnosis of post-traumatic stress disorder and behavioural problems. And I hear this quite a lot from the women coming into my debrief clinic, that they can find it extremely hard to enter the hospital, or even for some women to drive past it. You know, women living in the local area who will go a different route to get around so they don't have to see the hospital, which is a terrible thing to hear, and it's devastating that it's come to that. But certainly avoidance of situations that remind them of the events of the birth. And of course, it can impact upon the bonding with the baby. Thank you. Some of the ongoing consequences can, of course, as I've mentioned, there can be impacts on bonding and breastfeeding. It can affect relationships within the family. It can inflict, this can have lifelong consequences for women. It can affect their employment, of course, lead to self-harm and suicide, remembering that in the developed world, suicide is one of the top causes of maternal mortality. It can impact upon future pregnancy and birth decision-making, and I'm going to go into this a bit later. And it can have intergenerational impacts, and it can impact on the mum's ability to provide sensitive and attuned care, and therefore the child's security of attachment. It's got cost implications for the health system, and remembering that staff, as I mentioned as well, can be very much affected by birth trauma as well. And what we're increasingly seeing is that people who've had traumatic births or births that haven't gone how they wanted to, then declining care and increasing clinical risk and taking on the risk of further worse outcomes in subsequent pregnancies. Thank you. So just a little stuff, a slide about, well, what can we do to try and prevent it? And some of the research tells us that the most important factor is just the quality of the interactions with healthcare providers. We all know that there can be many poor outcomes associated with pregnancy, but where people feel safe and secure and well communicated with, and have the opportunity to have events explained to them, it can reduce their chance of developing birth trauma. So we do have this opportunity to set women up well, to feel safe and secure during the pregnancy, of course, during labour and birth, but then afterwards as well, to recover in the best way possible. And under this little image just tells us about when the higher cortex goes offline, when women are feeling scared and the amygdala is in charge, then they're sort of, if they enter labour in that way, and that might happen for a variety of reasons, but they're really preloaded to find events of labour, even just the pain of labour, that then progresses to a normal delivery with no complications, can be felt to be very deeply traumatic. So we just have to remember that when patients are in these situations, that we just need to remain calm, assume that their higher level thinking is not really as good as it would be in another situation, stay connected, make eye contact, smile, speak calmly, calm the anxiety within ourselves, speak slowly, and use plain English. Making these women feel safe and secured is just so safe and secure is so important. And remembering there's that long list of those who are vulnerable, but just it's better to consider that everyone might be vulnerable, so that you approach it in a really trauma-informed way. And validating their fear and validating how hard they found the experience goes a long way to helping people process what's happened. Thank you. So this is a good question, and the Panda would say that every patient should be given an opportunity to debrief their birth experience and then access additional support if that's needed, regardless of what happened during the birth, even where the outcome was entirely normal. From our perspective, even many of those women still require debriefing. And I had that experience today with my patient I can talk about a bit later. So there's a not particularly helpful Cochrane review that has got a really limited database, and it doesn't have many women within that group who actually experience their birth as being traumatic, but the conclusion isn't particularly supportive of debriefing, but I'm happy to ignore that in the face of other studies. One of them stated that 2/3 of women who found their birth to be traumatic, they certainly wanted an opportunity to discuss in detail what had happened, to make sense of it, to give feedback to the service, and to make plans for future pregnancies. And other studies just saying that it really should become the standard of care. And I feel very strongly about that every woman should have the opportunity to talk through the events of the delivery, and that may need to be escalated depending on what the experience was like for them, to higher levels of care. Thank you. So some of the things I've discovered through providing our service is what one woman, you can't always predict what a woman would want or need from an appointment, and everyone comes with a different lens and comes wanting something a bit different from the debrief service. So we try to start the appointments with being very open-ended, and give women the reins for guiding how the appointment goes. Now, we have the luxury of being able to spend 45 minutes to an hour per patient, and occasionally I'll also bring women back for second or subsequent visits. And sometimes the first appointment might be by telehealth because the woman's too fearful to attend the hospital, but then often I can get them to then come in, and the quality of the appointment's often much better when we're in person. But I openly disclose that I'm in a pretty luxurious position to have such a large amount of time to spend with these patients. I like to stress to everyone, though, that there's no point waiting until the woman's 3 or 6 weeks or 3 months postpartum to go through these things. Like, it really needs to start immediately after the birth by the team that were at the birth, then by the team that are looking after the woman on the ward or at home afterwards, by the domiciliary service, And of course, it needs really good communication back to GPs so that the GPs can continue to support women by talking about their births. I always, as I said, try to make it patient-led and just sort of probe how they found the labour and birth, but also acknowledge that what they want out of this appointment will vary, and I'm very happy to be guided, and we can just sort of step through what has happened. Often we'll start by just looking at a bit of a timeline, and then that quickly brings up the issues that the women want to talk about. It's a lot about listening and just validating women's experiences, and just by acknowledging that, yeah, what you went through was really, really tough, will often just go a long way to making women feel better and safe. And we have to make them feel safe in that appointment so that the appointment itself is a healing experience. And I'm not trained in trauma counselling, and we stress for our senior registrars that do this clinic as well, but that's not what we're there for. And some patients do need referral on. Thank you. And these are some of the sort of screening questions you could think about asking to identify who might need further referral. So that women are having flashbacks and distressing memories and thoughts, if they're not sleeping, if it's affecting their appetite, if they're irritable or frustrated, feeling on edge, if they're having difficulty engaging in looking after their child, if they're relying on alcohol or substances, or if they're, of course, harming or suicidal. And this goes across the board, isn't it, about screening for anxiety and depression. I'm sorry, there's a code about to go off.
Med call HDU bed 2. Med call HDU bed 2.
Sorry about that. You're probably all thinking, thank God I'm not at the hospital at this hour of night where I am. And just a little reminder there about the PTSD criteria, and that sometimes, we'll be concerned that it's got to this point and we need to then refer for more intensive psychology and psychiatry assistance. Thank you. So we have a few different avenues for care of women postnatally. So I've already talked to you about our debrief clinic. On the ward, as you'd know, we've got some ability to refer for psychology and psychiatry assistance, but we don't have much scope for providing that care for once patients have been discharged. And for people who haven't been linked in with perinatal mental health during the pregnancy, it's very, very hard for us to get them seen postnatally. So it's definitely relying upon community-based services after discharge. Any of our patients who have had a perinatal loss will be sent into our STAR clinic. And so just you are able to refer to that clinic as well for patients with 3 or more miscarriages, or with any sort of mid-trimester or later fetal loss. And that's run by Dr. Liz McCarthy, one of our maternal-fetal medicine specialists. The perinatal specialists who look after women with the really complex pregnancies, particularly fetal anomalies, patients needing procedures, etc., during the pregnancy, they will want to see their own patients back, and so they'll be seen by the consultant that knew them the most during their pregnancy. Patients who've got physical trauma, particularly 3rd and 4th degree tears, are coming back to be seen in the gynaecology clinic and through our physiotherapy service as well. And sometimes they come on and see me as well later. They can be referred to me through gynae clinic and by the physios. We're getting our MGP patients who've got that continuity of care to be debriefed in the first instance by their trusted care provider. I think that's probably where debriefing is the most successful, when you've already got a really solid relationship with someone and you can work with them to make sense of what happened. But sometimes where there's been a need for lots of medical intervention, or if there have been complex complications, they'll come on and see me in the debrief clinic as well. Our SAGE patients are the women who have substance abuse or who are socially vulnerable. They'll definitely go back and see the SAGE team, which is a multidisciplinary team with social work and psychology and some adolescent gynae in there as well. And then there's a big crossover between debrief and complaints. And I walk a fine line, and sometimes I'll see someone who's put in a feedback or complaint. Sometimes I'll see them in the debrief clinic, but usually we'll try and handle the complaints as a separate process. and through that complaints process, sometimes we'll realise someone also needs to come and have a clinical debrief, and we can do both. You are certainly able to refer in directly to the debrief clinic as well. I've had a few direct GP referrals now, which have been extremely valuable, and that's worked well for the patients. We grapple with a few issues. Our wait time at the moment, I did see someone today who was 6 weeks postpartum, but mostly we'll see women who are 3 to 6 months postpartum, just because of the duration, the wait list. And so I'm trying to really work on how we can more accurately identify patients who need to be seen in debrief. We are looking at introducing a birth experience survey to all women that they'll fill out on their phones, and it's got a scoring system, and whether or not this would more accurately identify women who are needing to come and see us, because we do have quite a high FTA rate, which is rather devastating when we know there are women who desperately need to come in and be seen and who are waiting. And sometimes I think there's a bit of distress amongst nursing and midwifery staff on the ward when a woman is distressed, and there's a bit of reflex referring. So we're trying to move away from that, and also put together an information handout so patients are aware of exactly what the service is about, because I'm still surprised also by people who turn up dutifully to their appointment, but they don't really know why they're there or what it's for. So we're just trying to improve communications, and gosh, I welcome feedback on how we can do it better. The other thing that I'm really trying to do is look after the people who do the debrief clinic, because it can be pretty heavy. It can be tough going for some clinics. So looking after the senior registrars in particular who help me with that clinic, and then honouring women's stories and making sure we capture any care deficiency problems that are brought up during the debrief appointments, and so that we can feed that back into the system for quality improvement, and just to be able to capture that feedback and do something with it rather than just letting it go. I don't think that's like really doing the right thing by women to not try and make it better. Thank you. So this is a document that you will have access to. It's quite a lengthy document, and I'm not going to bore you by taking you through it sort of page by page. But I'm going to take you through the key principles and explain to you how we use it. We had to develop this in relation to a few poor outcomes where we had patients who were declining various different elements of care, who then, as a result of that, as a result of people not really knowing how to approach the situation, and perhaps communication that wasn't as clear as it could have been, ended up having quite poor outcomes. And this document was developed to protect patients, but really also very much to protect staff, and to give us a framework to use when we are in this really difficult situation where patients are declining care that's recommended. Thank you. It's got a couple of different elements. When it's antenatal, there's much more time to talk about the situation, and it's a bit of a framework for people to go through when it's an antenatal element of care that's being declined. And that happens relatively frequently, whether it's a GTT or GBS swab that's declined, or sometimes even an ultrasound. But then the middle flow chart shows you what we work through when we've got someone in labour, where it's a little bit more emergent, and we have to really work with a woman in a structured way if they're declining our recommended care, particularly in an emergency. And then there's a bit of a communication checklist. There's also, that's okay, thanks Richard. There's also a handout just on the next slide that patients can be given as well, which has got this really useful brand prompt just to help patients structure the questions that they're asking, understanding what are the benefits of being what's recommended, what are the risks of not doing it, what are the alternatives, do I have to decide now, or can I choose to do nothing, and what their final decision is, and that's totally up to them, of course, at the end of the day. Thank you. So some of the key principles about that document and how it's applied is that, look, at the very least, we can't harm women by not respecting their autonomy and not respecting informed consent. And this can cause huge angst for staff when they're really genuinely worried about the well-being of a mum or baby. But we just cannot ever do anything against a woman's will, and we must respect her ability to choose to do something or not do something. It's really important that you're aware of your own cognitive biases when you're counselling patients, and I'll talk you through that in a little more information, because that can influence how your counselling comes across. We try to have engagement with the most senior member of medical staff wherever possible, and it's really important that you just keep rediscussing the situation as things evolve, and as if there is an increasing risk or new risks added, that it's important that you rediscuss the situation. And I'll talk you through that in a little bit as well. Just the next slide, please. So principles, of course, communicate, and then document it all in as much detail as possible. You've got to just document, particularly in labour, that the woman has got capacity to make a decision. It's really rare that that's not the case. It will happen occasionally. What is the recommended care that's been declined, and what are the benefits and risks of that recommended care, and what are the risks of declining care. So that's been carefully explained to a patient, and you document exactly what you've explained and why. That the woman's had the chance to ask questions, and you can document any questions that they might have had. If appropriate, that you've had an interpreter or a cultural support worker present, and who were the other people present for the discussion, whether there was the partner or any other support people, doulas, etc. It's super important that we communicate within our teams as well. And when we're on the birth suite in particular, we would encourage all of our staff to seek advice from the midwifery unit manager, the AMUM on duty for that particular shift. And we definitely want consultants involved where patients are declining important elements of care in labour. And then, of course, sometimes we get to the really pointy end where patients disengage from care with us and have an intention of free birthing or having a home birth outside of the hospital home birth program or with unregistered practitioners. And I think in this situation, we really need to be trying to communicate with our GP colleagues, the referring GPs, providing information to home birth midwives where we can, etc. Thank you. So isn't this amazing? There's a systematic review about clinicians' expectations of the benefits and harms of treatment, screening and tests, which is very interesting. And it raises this concept of the therapeutic illusion, whereby most of us overestimate the benefit of a treatment and we underestimate the harm. That is, we're over-optimistic. And this can lead us to try and push treatment options towards patients and try to convince them to accept what we're advising. But this may end up leading to a higher rate of interventions that aren't necessary or desirable. So it's really important to understand the factors that influence our assessment of risk. And that could just be personality based. It could be based on past experience, particularly recent experiences. If you had a terrible thing happen in the birth suite, you're much more likely to be fearful of that happening again. Or likewise, if something went well, you might be more proactive about it, recommending it for subsequent patients. It's much easier for us to do something. We're trained to do things rather than in obstetrics. Sometimes the best thing actually is not to do anything, just to sit on our hands and wait and allow the situation to unfold, particularly in labour. We're definitely driven by, at times, a fear of malpractice and of being sued. And we can often tend to rely on relative risks rather than absolute risks, and use that to try and convince patients of instead of saying the risk will go up from 1 in 100 to 2 in 100, we talk about a doubling of risk, which can be quite alarmist and isn't always representing the truth and putting things in the proper perspective. And so I teach my staff to be really aware of trying to coerce patients to agree. We mustn't magnify risk estimates. We mustn't exaggerate benefits. And we can't ever demean patients for declining care or accusing them of trying to put their babies at risk. And we can't threaten to withdraw care if the woman doesn't agree with whatever pathway is being proposed. We always have an open door, and we always have to provide care to that woman in the future. Thank you. Really, really important that in these situations where we become aware that a patient's declining care, particularly in the labour ward, we go straight to the most senior doctor that's on that shift, which will usually be our senior registrar or a consultant. It's what you don't want to see is it start off as a conversation with a resident who then gets their registrar, who then gets their senior registrar, and then eventually the consultant, because from the patient perspective, that can seem very intimidating and coercive. So we find it's much better if we try to have a single person speaking to them about the issue and try to maintain continuity and make it someone quite senior. This second point is really important, that patients, to withdraw consent, it doesn't have to be informed. That is, they can decline to even have a conversation about the risks and benefits, and we have to respect that. So we don't have to tell them all of the risks that might come up. If they say they don't want to talk about it, that's all that we can do. We can't badger them with trying to give them the facts. But we've made it really clear that any refusal from a patient to have counselling and to discuss the issue has to come directly from the patient to the obstetric registrar or consultant. It can't be a partner saying, oh no, she doesn't want to talk to you, or the midwife saying, oh, the patient doesn't want a doctor to come into the room to talk to them. It has to be the patient directly saying that to the medical staff. That's really to protect us legally, but also just to make sure there's no other factors going on in that team relationship, and this is truly the woman's preference. We want to hear it directly from her, and we'll respect that. Thank you. Oh, sorry, just back. Yep, there we go. So sometimes a patient will signal that they're going to decline, say, for example, monitoring in labour, and we just want to always reiterate that they can change their mind. They can change it both ways. If they'd previously agreed to something, they can withdraw consent. But if they had signaled that they weren't going to do something, they're of course allowed to change their mind. And it's really important that as the situation evolves, for example, as if they developed a fever in labour, that's a new risk, and we have to rediscuss the importance of now monitoring the baby. You just have to keep, you can't assume that a refusal for an element of care applies in all situations. You do need to discuss it with each situation as it evolves to make sure the patient's making an informed choice. And yeah, that sort of covered off on that last point as well. Thank you. When I was just reflecting on this talk, I'm doing a Masters of Healthcare Leadership, and this quintuple aim, it was the triple aim, then the quadruple, and now quintuple aim kind of comes up as, and it's a good reminder just to think about, like, why are we here? Why are we doing this? And it's, you know, we want patients to have a better experience. We want them to have better outcomes and therefore improve population health at a higher level. We, of course, want our staff to be physically and psychologically safe. We want to be effective and efficient, and we want to provide equitable access to care. And so in thinking about those aims, if I can just go to the next slide, some of the work that we're doing is really trying to come back to not just doing things to make people happy, but really trying to hone in and provide much more patient-centered care to try to reduce the issue of birth trauma, of patients being blindsided by their birthing experience and finding it traumatic. And then the subsequent problem that happens where they're so traumatized by a previous birth, they start making choices that increases the risk for them and their babies in subsequent pregnancies, or the total disengagement from maternity care, which we sometimes see in women free birthing. So the way we're trying to do that is really improving the quality of antenatal care, antenatal education, I should say, and care, but antenatal education. So women have a much better idea of what they're likely to experience, what the outcomes are, set really realistic expectations, and be honest with women, not trying to sugarcoat it as this amazing experience that they'll, you know, forever look back fondly upon. But let's be real and set them up to succeed. We're looking at expanding our midwifery group practice program, understanding that there's good evidence that that continuity of care with a trusted provider can result in some much, much better outcomes for women from an emotional and physical point of view. Looking at improving the care for women who are high risk as well. So for those that risk out and can't have just midwifery care during pregnancy, through our yellow and red pathways, like how do we make that a better experience for them and improve continuity of care for those patients? As you're probably aware, we've most of the tertiary centres now also offering water births, and also there has been an expansion of the home birth program prompted by Safer Care Victoria after this rising incidence of free births was noted, particularly during COVID. And very proud that Mercy also has a home birth program now, which is going incredibly well. And that's giving women the option and trying to engage women who wouldn't have ordinarily had hospital care, but to safely be able to provide home birth to them. I think that the role of feedback is incredibly important. And then just to finish on, I think we're getting close to the end. I'd like to leave time for questions, but we're embarking on a new operative vaginal birth bundle, which is trying to provide forceps and vacuum deliveries in a much more patient-centered way, using a timeout and safety checklist to really make sure the woman is understanding why it's being done, that they understand what's going to happen if it's not working, what are the additional aspects of care associated with having an instrumental delivery, such as an episiotomy, catheterization, pain relief, and then providing women with the opportunity for good debriefing after that happens. And you'll see this being expanded across the state, and you'll see a real shift in culture associated with this bundle that's going to become compulsory for all of the public hospitals to be using. And a part of that is the patient experience survey to try to identify who needs more advanced debriefing and care postnatally. Thank you. So we come back to this slide that I said to you I would finish on, or almost finish on, just remembering that we're all after the same thing at the end of the day. And I know that you know that, but we've just got to work out ways to work together and improve the way that we provide antenatal and intrapartum and postnatal care to achieve this, beautiful picture of such a happy family with a happy mum and healthy mum and a healthy baby. And this picture of the trio reminds me as well that I often have the mother of the woman coming along to the debrief clinic as a support, and we often end up talking about her birth and this reflection from these grandmas about how they had wished they'd had the opportunity to debrief their birthing experiences, because here they are all these decades later and still living with the trauma of what some of them went through when they delivered. So that always, I find that poignant that the women have suffered in that way, but also special that we can now try and improve that situation and do a better job of caring for women after they've had babies. So a few resources for you, stuff from Panda and Birth Trauma Australia, and some courses if you're particularly interested. Some are free, some come at a smaller cost. Next slide, please. And then lots of oh gosh, it's very small. You'll get copies of this, you'll be able to see, but lots of academic references if you're interested in looking that up as well. And as I mentioned, you'll also get a copy of our guideline about patients declining care if you're interested in reading up on that a bit more. So thank you very much for listening to me talk about an area that I'm still learning about and that is very much evolving for me. And yeah, I would love to get some feedback from you and answer any questions you might have in the area.
Thank you, Jill. That was very insightful, and I think on a topic that can be very, very challenging to manage in general practice. I'll start with some of the questions. The first one I've got is, are there any tips of talking to a patient who is higher risk and planning a home birth? And I guess I'm going to add to that. Sorry, the question also added a home birth outside of the system. And I'm going to add to that, is there any risk for a GP providing a referral for a home birth? Because it's been noted that some GPs have been asked to provide referrals to midwives with the medical information, which could have implications on like medical legal responsibility. So I wanted to throw that out there.
Oh, good question. So in my experience, we'll often see patients in antenatal clinic, well, not often, but I've certainly had some over the years, and they sort of signal that this is, that they're planning on having a home birth. And then, of course, the same could be said for GPs and patients signaling that to their GPs. My approach is just to not tackle that sort of head on at the very beginning and try to talk them out of it, but to just really like keep building the relationship and to try and understand why and what it is that is more appealing to them about home birth versus having their baby in the hospital. And that may be to do with birth trauma that they've experienced in the past, and trying to have the time to just go through what their past experiences have been and what they're fearful of, and try to find common ground and compromise sometimes in, not doing things exactly how we would always normally do it in the hospital labour ward, but just trying to find avenues just to keep them engaged and at least have them come here to deliver, particularly, of course, with free birthing, but I think home births outside of the system as well. Like, there's just so much risk associated with that, and such a late transfer rate that we see with really horrendous complications sometimes. Even if they're here on site and they won't let us do anything whatsoever, at least we're here if things go badly. So we just shift our expectations to just at least keeping them able to attend and be here for the delivery. So that's my approach. And very frequently things shift and they end up coming around, and they do end up coming here and agreeing to various things that at the very beginning they had said they didn't want to have. And also making sure that we're being honest and we're only recommending stuff that's evidence-based, that's actually beneficial to them. In terms of the second part of the question, that I had never contemplated that GPs might be asked to refer for home birth. I presume that's to the registered home birth midwifery providers, because there's implications in terms of billing and accessing provider number, accessing item numbers for the midwives, and they must need some sort of referral for that. I think it's tricky, isn't it? I think if you've got someone who's, it's different if you've got someone who's low risk, who is fairly straightforward, versus those much higher risk situations, such as women wanting to have vaginal births after cesarean section in the home birth setting. I would approach that with caution. I think you just would want to know what the clinical governance is of the setting that you're referring into, and by referring to that, are you implying that it's safe and that you think it's a safe service? And you may have good knowledge of some of the group midwifery home birth programs and feel that it is safe. That's different. But I think I'd be a bit cautious about that approach. Knowing that there is an increasing number of home birthing options for patients in the public system too, that you can refer to. Yeah, I think that's a hard situation. I'd have to think about it a bit more as well.
No worries. Yeah, I guess I'm remembering an article, I think it was about Bendigo Hospital, where the GP had made that referral, and then the patient had claimed because the GP had made the referral, she felt like she was low risk. So it can be a very dangerous situation.
Sort of validates the situation, doesn't it? Yeah, that's a very, very difficult situation.
I've got a question here that says, what is the definition of free birth, and why would a woman who wants a free birth engage with a maternity hospital?
Oh, so I think the definition of free birth is birthing without a trained healthcare attendant. So, in our context, not having a midwife present for the delivery. There's definitely going to be a cohort who never engage with mainstream medical organisations, and that's a sort of we're a bit blind to that. And my colleague who's doing research on some of those outcomes it's very hard. We'll never really know the denominator, like how much this is happening. And maybe some of these babies then don't get registered as well, and everything's all a bit off the grid, don't know. But so I think that's the definition. Not everyone is very, some people have ambiguity, I suppose, too. Like they have a sense of, this is something I'd quite like, but also I'm a bit fearful. And so sometimes they do dip the toe in a bit and see doctors and get scans, and there's a bit of both, I think. So I guess it's just an opportunity, if they are presenting for any kind of care, to try and engage them, albeit something that's very challenging to do at times.
Yeah. Yeah, definitely can be. But I guess this is about having that difficult conversation with someone who may come to the party with a very different point of view at the beginning. The next question is, in your experience, what are the top 3 things that women tend to decline, 1, during antenatal care, and 2, during labour birth?
Ooh, I think there's so many different scenarios. Some of the more common, I mean, as I mentioned about antenatal care, we do commonly see people declining GBS swabs and GTTs and things like that. And there's ways around that. But I think you'd want to escalate that as a GP doing shared care. If you've got, particularly with the GTT, escalate that for an opinion from the hospitals. In labour, it's often around not wanting vaginal examinations to assess progress, or not wanting fetal monitoring, particularly in the context of previous caesarean sections. Not wanting intravenous strips put in for women at increased risk of bleeding. Certainly, yeah, declining antibiotics for prolonged ruptured membranes. And then sometimes declining episiotomies, or declining vacuums or forceps to expedite delivery where there's fetal distress or prolonged second stage. And of course, not agreeing to caesarean section delivery in some contexts as well. Yeah, I think the full gamut we see. Yeah,
I'm sure you've probably got stories about each one. I know we're running out of time, so I'll pick a couple more. Joe, feel free to butt in there if you want to add anything. One question is about home birth. So if a woman has chosen home birth and they are happy to go through a hospital, how do we make that referral to the hospital? And then once they go through this process and have the home birth, is newborn screening available to happen in this home birth setting as well, provided it's through a hospital?
Yeah, I can talk about our program, which ours was really based upon what was being done at Sunshine, and I think there's it's quite similar across the hospitals that provide it. It sits within a midwifery group practice. So to access home birth, the patients have to be referred to the midwifery group practice, and that certainly requires early referral. Like, we know that those programs are really popular. So I would prompt anyone whose patients might be interested in that to send them through, refer them on early, highlighting MGP and interest in home birth. There is a really careful risk stratification, and there will be patients who are no longer eligible for home birth based on that. So, and the relationship that MGP midwives make with their patients planning home births is really one that it evolves over the pregnancy, but it's really got to be about mutual trust. And the midwives will only continue on with a patient and do a home birth with them if they're very, very confident the patient will listen to them and do what's needed if there is a complication or an emergency. So patients who are really declining basic elements of care will end up not being able to continue with the midwives doing home births, because they really don't, we don't want our staff in that situation, but those midwives don't want to be in that situation either, where they're kind of, in a really hairy, high risk obstetric emergency in the home. So that's just a bit of a caveat about that. So how do they get in? It's through referral to MGP. And then if they risk out and they can't have a home birth anymore, they still remain in the MGP program, and they'll still have their midwife looking after them, but they're delivering at the hospital. rather than at home.
Okay, and the newborn screening test can happen
yeah.
I assume in that situation. Yeah.
Yes, because midwives will provide the awesome postnatal care and follow up, so they'll return to do that at home. Yeah, for the patients. Yeah.
Cool. I'll try and bring it down
come
to
on site, just with the hearing testing. They have the opportunity to then attend on site for newborn hearing testing, hearing screening.
Yeah. I will try and bring it down to 2 more questions and then hand it over to Joe to close. But yeah, we've got lots of really good questions, and if we don't get to them, if people can still send them through, and I'll make sure we pass them on to Dr. Jill. Someone has sort of mentioned that they often find women very combative in this area who've been through previous birth trauma. They don't want to hear about the risks, benefits of certain interventions. They've made up their mind. And despite trying to be compassionate and open, it's very difficult when they're angry to begin with. So how can we deliver the information that's important in this type of situation?
Oh, it's so challenging, isn't it? As I'm listening to that, I'm remembering various really difficult conversations I've had with people. I think it comes back to going slowly, just chipping away over time, trying to understand like where that anger comes from. It's probably based in fear and trauma, and someone who's really, really scared and who wants control of an uncontrollable situation. So I think just trying to maintain compassion, also just be kind to yourselves, because it can be really, really challenging. So like just acknowledging that, these are hard conversations. You need to give yourself time after you've had them to sort of come down, and you talk to your colleagues. We all debrief with each other all the time about these situations. I think that for me, like the goal I keep in mind is I could just want them to stay engaged. So just like keep coming for monitoring of the baby. They might not want to see a doctor or midwife in clinic, but they'll come to fetal monitoring, at 42 weeks gestation, because they want to know their baby's okay. So it's just like just to be clear about what the bare minimum you really want to try and maintain. And then often you can then get them to agree to other things as is required. But it is really challenging. It's like the hardest bit of what we do, I think. Like the actual doing the vacuum or the forceps or the Cs is kind of easy compared to this stuff.
Yeah, because this stuff is so variable. And the final question I've got is just regarding pregnant women on temporary visas who refuse antenatal care through the public hospital as they wish to deliver overseas. Any recommendations? And often I'll throw cost in there as a barrier as well. Some of these women do see it, going through the system can be quite expensive.
Oh, it's very hard, isn't it? I mean, how can we not have a situation where we just provide free care to them? It's really very challenging, but that's the reality, isn't it? I think, well, if they're planning on delivering elsewhere, I think we still have a duty to try and provide them with excellent antenatal care. I don't have an answer to what we do when they can't afford it. And we certainly see that coming out in people not attending because of cost. It's really difficult. I think if they can afford to see their GP, this is the perfect time when GPs can step in and help provide some of that care if they can't afford it at the hospital. Sorry, there goes off another buzzer.
All clear.
That's good. Patient's okay. Level 6. I'm not on call, by the way. I'm not neglecting someone to speak to you all.
Level 6, HDU.
Yeah, I think I don't have an answer beyond that for that scenario. It keeps me awake at night, though, worrying about those patients.
Thank you, Dr. Jill. I'll pass it on to Joe, who can basically do the wrap up. Thank you.
Great. Thanks, Jill, for a fantastic presentation and really quite thought-provoking. And Peter, I think, has gone. So we thanked Peter previously. So I think been great sessions tonight to prompt us. There's some site-specific issues that people have raised. So we might, put a little blurb in, but I think from the Western point of view, we don't have a formal debrief clinic as someone's identified. We do have community liaison midwives which are a good point of contact, and then they will arrange for the patient to have a debrief within their clinical team, so whichever team with the senior consultant who was most involved in their care. And I think the other comment is around antenatal classes. I think everybody's really quite stretched. So an important reminder to tell your patients that they'll be informed about their hospital antenatal classes at their booking visit, and important that they book in early at that time, because the ones I see in clinic that are 30+ weeks, there's no way they're going to get a spot. So just a prompt for GPs when they're doing the referral, because often the patients are thinking about all the other things, but not childbirth education. All right, so thank you everybody for attending. Thanks to Richard for facilitating all the questions. It'd be really helpful if people can provide some feedback. So either scan the QR code or respond to Yvonne's email that she'll send out, because we like to hear from you about how the session was for you, what you'd like to hear about for coming education. You know, sometimes we feel like, oh, what are we going to talk to people about for this shared care workshop? What haven't they heard from us? And I think tonight's sessions have been really fantastic and things that we haven't covered off for some time. So Yvonne will send out your links to the recordings and a copy of the slides and resources in the next week or so. And so you'll be able to go back and watch things. And we will see everybody online next week for session 2. If you're unable to attend, again, the recordings will eventually be available on the PHN website. So thanks everyone for your time this evening. Thanks Jill and Peter for all the effort you've put in, and we'll see you all next week.
Sure.